explained to him using this graph, and fortunately agreed for the toric IOL. And this is the post-operative part of the same patient, where the entire corneal astigmatism is almost completely neutralized by the internal toric IOL astigmatism. Now coming to these fancy terms of angle alpha and angle kappa, if you notice here that the abrometry or any eye has 3 points. That is, first the center of the limbus, the center of the pupil, and the visual axis. Now the patient is the rays of light are going to pass through the center of the visual axis, whereas the IOL is actually going to sit in the center of the capsular bag. So if the angle alpha, that is the angle between the center of the visual axis and the center of the limbus, is quite off, then what will happen is that although you may do a perfect surgery, well-centered IOL, what you feel in the bag, post-operatively what is going to happen is, with this large angle alpha, the patient's visual axis is actually going to pass through, if you notice here, through these multifocal rings. This is going to lead not much of a refractive surprise, but this is going to increase the photic or mesopic phenomenon that the patients are going to have post-operatively. So therefore, more chances of glare and halos. And for now, there is no golden cutoff line, but most experts believe that anywhere around 0.4 to 0.5 angle alpha should be considered as a red flag or a cutoff for multifocal IOLs. If there is one investigative technology which I think has revolutionized not only retinal surgeons but even all general ophthalmologists, I think that is the optical coherence tomography, or the OCT. And so often we come across these absolutely healthy looking normal retinas having a distorted foveal contour because of epiretinal membranes. And therefore we decided to conduct a study to find out how many patients who are undergoing actual cataract surgery have macular pathology, which a retinal surgeon has put up in his notes to be a normal retina and a normal fundus. What we found in our results, the good part is that in 95% of the eyes, we could capture an OCT. So the OCT is able to capture even in very significantly dense cataracts. So it has a good penetration. In what I said, in those diagnosed with a normal fundus by a retinal surgeon, beware, OCT examination revealed ERM in 7% eyes, RP irregularity in 4%, and foveal attenuation vitreomacular attraction in about 3%. So all of these patients were missed out not just by the general ophthalmologist, but even by the retinal surgeon on 78 and 90D clinical examination. And this is a classical example of a normal looking fundus showing a vitreomacular attraction or an early lamellar macular hole in the post-operative period. And coming to finally the corneal investigations, they may not be required in all situations, but particularly in abnormal or special situations like this, where you are considering toric IOLs, where the readings are showing, may or may not be showing great astigmatism, you need to look at the regularity of the astigmatism. And more importance is now being given to the posterior corneal curvature, not just as far as detecting pathology goes, but also as far as IOL power calculation goes. And there are devices now or instruments which measure the posterior corneal curvature, like the pentacam. If you see here, this is the topography map, this is the pachymetry map, this is the anterior elevation and the posterior elevation. And you may be able to pick up cases like this with high posterior corneal astigmatism or elevation, which may be suggestive of a form-fruste keratoconus. And these are the patients where you want to avoid a particular kind of a premium IOL. So I think newer diagnostics, of course, not everything that comes new is good or useful. There have been, instruments which we have bought and we have found after 6 months they are of no use to us. But I think we need to have a positive mindset and keep moving forward. And newer diagnostics, I think, are going to help us to raise the bar as far as expectation managements are concerned, as far as creating more and more happy patients are concerned, and in creating more predictable and precise outcomes. So thank you very much. I would now invite Dr. Abhay Vasavda to talk about customized IOL solutions for each patient. Yes, we can have questions after every talk, if there are any. Okay.
While we are waiting, I want to recognize two individuals in the hall, past President Dr. N.S.D. Raju and the President Amulya Sahu of the manual small incision cataract surgery, which is promoted all over the world. So thank you, sir, for attending. And those who are still doing this wonderful technique of small incision, manual technique, everything we say is relevant 100%. You can do exactly the same detailed preoperative evaluation. Consider what kind of IOL will put, when will you put, and so on. So just stay tuned with us, and you will be okay. We all receive research grant support at our center from Alcon, but has no relevance to this topic, except that you will hear or see restore return, which is a synonym of traditional multifocal lens.